Good morning and good afternoon or good evening, wherever you are in the world. And also, if you're watching this afterwards, hello, and thank you for coming to join our GTC webinar on Beyond the Voice, the benefits of one-way speaking valves. I'm delighted to be a moderator at the webinar. I'm Amy Freeman-Sanderson. I'm currently serving as the Vice President of the GTC. This webinar has been brought together by our Education Committee leads. So Sandy Foster is our co-chair. She's a clinical nurse consultant with over 25 years of experience at Monash Health. She has extensive experience supporting children with complex medical needs, and she currently works as the Pediatric Tracheostomy and Respiratory Services clinical nurse consultant. Sandy's dedicated to strengthening continuity of care and improving outcomes for children and their families. Michael, our chair of the Education Committee, is a respiratory therapist based at UVA Children's Health in the US. He co-founded and developed the institution's Pediatric Home Ventilator Program. He's also a PhD candidate at the in health sciences at Rush University. So we've got a wonderful panel which Sandy will be introducing. But just a reminder, if you have any questions, any comments, this is interactive and all of the knowledge and the questions build through the community. In the bottom of your screen, you'll notice a Q&A button. Please post any questions along the way. We do have time for a panel after the speakers, so please pop in your questions there. And with that, I'll hand over to Sandy.
Thank you so much, Amy. I'm going to read out our objectives today for this webinar, and we're going to discuss one-way speaking valve use across ventilation modes, discuss how clinicians can determine when a one-way speaking valve is safe for use. We will describe strategies to safely monitor and manage one-way speaking valve use across multidisciplinary teams and care settings. We'll list the therapeutic benefits provided by use of one-way speaking valves, and finally discuss how clinicians, families and patients can collaborate to incorporate use of one-way speaking valves into therapeutic regimes to improve quality of life. I'm now delighted to be able to give you an introduction to our panellists. We have Lisa Terry, she is a speech pathologist, Michelle Patton, an advanced cardiac and critical care physiotherapist, Viren Kaur, he's a critical care physician, Louise Edwards, an independent paediatric speech and language therapist, and last but not least, we've got Hayley, who's an emergency department nurse with first-hand experience as a parent of a child with a tracheostomy and a one-way speaking valve. Our first speaker today is Hayley. Hayley is a wife and mother of two. She's been a registered nurse for almost 10 years. Hayley is a full-time caregiver to her medically complex 3-year-old son, Weston. Weston was born with Charge syndrome and required a tracheostomy, ventilator, G-tube, and extended NICU stay following birth. Weston used a speaking valve for 17 months, which helped with many challenges in their day-to-day life, and Hayley loves sharing their story in the hopes that it will help other families deal with the challenges that come with having a medically complex child. So I'm now going to hand over to Hayley.
Thank you, Sandy. So like she said, my name is Hayley. I'm a registered nurse and a mom of two, actually. I have a 4-year-old and a 3-year-old. And just a little bit of a backstory about Weston. He was born with a Charge syndrome, like she mentioned. That was a totally unexpected diagnosis. So we got that and didn't really know what we were in for. He was quickly taken to the NICU, ended up having a 3-month NICU stay, and at 22 days old, after being diagnosed with bilateral vocal cord paralysis as well as the facial palsy from missing his right facial nerve, he received his trach, G-tube, and was placed on a ventilator. After that, we received extensive training on how to care for a child like this, and before we were even allowed to take him home. And if you didn't think that was chaotic enough, we got to take him home, and that's when the real chaos began. We were not only learning to navigate life with a medically complex child and all of his medical accessories, as we like to call them, but we were also navigating life with 2 under 2. We very quickly realized that one of the biggest challenges was Weston's secretions, and how copious they truly were. It it ended up taking over about every aspect of our life. We missed out on trips and daily, you know, things in daily life that you would be doing as a family of four because it just consumed us. It not only, affected my quality of life as his full-time caregiver and his mom, it affected my husband's, his older sisters, and it mainly affected his. We realized that because we were having to suction him every 1.5 to 2 minutes, day in and day out for months on end, that he wasn't meeting milestones. I hadn't heard him talk. And as a mother, that's, a really hard thing to come to terms with. And it just, overall was affecting him from thriving. So we received a little bit of, I would call it kind of pushback from his medical team occasionally. And I left a lot of appointments feeling discouraged because I just felt like no one really knew what to do with the situation. And so I did some research on speaking valves, and I came across a Facebook page actually for moms with babies who have tracheostomies. And I had a mother that was getting rid of a brand new speaking valve. So she sent it to me. And I held on to it until we went to a pulmonology appointment. And that's where our amazing respiratory therapist, who was actually Michael at UVA, gave us the go-ahead to try a speaking valve, saying maybe it would, in collaboration with his health team, of course, maybe it would be something that would benefit him. So we tried it, and we failed miserably. But that was just the beginning. So we continued with daily life and continued with multiple therapies to multiple doctor's appointments. And at this point, I was basically complaining, as for lack of a better word, to anybody who would listen to me within his healthcare team about his secretions and how to manage it. But in May of 2024, I just decided one day that I was going to try the speaking valve again. And I did it. And it was like a little flip switched in Weston's brain. And he just knew what to do. He started breathing, and it took about 3 full days of slowly introducing the speaking valve before he was able to fully tolerate it. He began tolerating it during all waking hours. He was on the ventilator just at night. And in that time, he started walking. He was talking. He was babbling. He knew his ABCs. He was counting. It was truly wonderful as a parent to watch him just take off. So he was on the speaking valve during all waking hours for 17 months, from May of 2024 to July of 2025. July is when he came off the ventilator, and he is now, I can say, he was on the speaking valve up until October of 2025, and he was successfully decannulated at that point. He is now a normal 3.5 crazy little boy who's going to preschool and just really flourishing, and it's really quite something to watch. So I'm hoping that our story can help someone who's maybe dealing with something similar. We went from suctioning him every 1.5 to 2 minutes to the speaking valve really quite, changing our lives, and us having to having a break of not having to suction him ever so often. We were having 4 to 5 hours in between, which was incredible. And it just really improved everyone's quality of life here. So thank you for listening to my story. Hopefully it can help someone. And I appreciate you listening to me today. Thank you.
Thank you so much, Hayley. It's really great to hear how much, the speaking valve helped with his secretion management. And it's amazing, this is why we do the work we do, listening to you and, learning from parents. And it's fantastic. And it's great that you were able to retry the speaking valve and didn't the first time that, that it failed. So that's amazing.
Thank you so much.
Thank you. Our next speaker today is Louise. She's a speech language therapist with almost 30 years of clinical experience working across settings mainly in the National Health Service, charity and medico-legal sectors. Louise works as a freelance speech-language therapist, primarily focused on airway disorders, offering supervision and mentoring, as well as supporting education and research and facilitating knowledge translation across global settings. She's also an invited guest lecturer at University College London and De Montfort University, UK. Louise is due to complete a professional doctorate in health at the University of Lancashire in 2027. Her research explores speech-language therapists' lived experiences of working with children with a tracheostomy in community settings.
Thank you so much, Sandy, for that introduction. And thank you, Hayley, as well, because I think it really sets the scene for us thinking about children with one-way speaking valves. So what we need to think about is children and how they present and how we need to think slightly differently when we're thinking about one-way speaking valves. The first thing we need to think about is the anatomical differences. So these are not just children with little airways, but these are children with different developmental contexts, different experiences, and can have a tracheostomy placed from birth, so at delivery, all the way through to adolescence and obviously into adulthood. So what we need to think about is the child in their context and how having a tracheostomy placed interrupts things like firsts. So for example, Hayley spoke to this, but the first kind of hearing a voice, that first cry, all the way up to adolescence where a tracheostomy can interrupt identity and voice and how you may appear with your peers. And so a one-way valve is beginning to offer us opportunities to think about how that may look different. We also need to think about how in children a tracheostomy is placed often for more longer term needs rather than for just weaning ventilation or for a short period. What we typically see is that a tracheostomy is placed for children with long-term ventilation needs, so those children requiring a ventilator in the longer term, and also those children who need a tracheostomy for upper airway obstruction, for example. And that raises thoughts and challenges about how we may support these children. And when we think about a one-way valve for children, we need to think about this idea that their airways are very susceptible to change. And so when we assess a child with a one-way valve, we need to remember that when we assess them, they are at risk of change. Compared to our adults with tracheostomies, what we understand is that resistance can change. So if you imagine, the small airway of a child, a millimetre change in that, so a tiny change in that can cause up to 75% obstruction, whereas an adult, a millimetre change may be 25% obstruction. And if we think about when we place the one-way valve, if we look at this graph here or this diagram here, what we're trying to indicate is airflow that goes up and around the tube, up to the voice box and up to the upper airway. Sorry, jumping the slides a little bit, but up to the upper airway, and that is an indicator for lots of different functions. So, for example, use for secretion management, which Hayley certainly spoke to very clearly. If we don't have sensation up to the larynx, children will sit with secretions and will struggle to manage those. Similarly, it's why I certainly personally don't call them speaking valves, and at the loss of an alternative word, certainly I'd like to acknowledge my colleague Jo Matthews, who she and I have had lots of discussions about how we can rename this valve, but it's really emphasising it's a multi-system valve, which for children is really relevant and very pertinent to development. So what we're talking about is voice and organic noises. So you're crying, your sighs, a valve can support that. And then when we think more about interthoracic pressure, we're thinking about cough and to protect and eject. We're thinking about gas exchange, so getting that end pressure. We're also thinking about trunk stability, which is really important for our developing children who are learning to crawl and to sit and to hold and be positioned. And another area that doesn't get talked about as much is that the valve helps close this system so that you can bear down for children from a toileting point of view. That's really relevant. So what I want to really emphasise is one-way valves, as we've heard from Hayley, really do make a difference, and they can have such an impact on all these multi-system functions. But what we need to be very cognizant of is that for a percentage of the children that we see, a small percentage, but a significant percentage, may never ever be able to progress to a one-way valve. And that's because the reason for their tracheostomy means that they're unable to either tolerate or manage a valve being placed. They're unable to get airflow up to their voice box, or they're unable to manage that closed system. So for those children, it may be that a valve, until innovation, perhaps even surgical options are available, that's not a possibility. And on the other side of that, we have those children where we've looked at those determinants for success. So the team around the child, we're all looking at how we support them, and we're ready to go. We can get that valve on, being mindful of the changing airway that can occur. But for lots of our children, what we do find is that it may be a no, not now, but not a no, not never. So it's a bit like Hayley was saying with Western, that, you know, they went back to that decision and they kept looking. It's being curious and being open. We need to remember that the tracheostomy tube and size makes the difference to success of one-way valve. In children, this is particularly pertinent because that's small changes in millimeters, that, you know, a millimeter difference can increase obstruction, can resist airflow. The underlying etiology, as I said, some children it may not be appropriate. The reason for ventilator dependence, if you have a child that you're unable to successfully or stably remove them from ventilation, it can be a challenge. Again, children are respiratory vulnerable. Their respiratory system is the priority. And the timing's really important. What's going on for family? What's going on for the environment? Where is it taking place? What's the support look like for this family? It's being realistic and human, and I nod to my colleague, particularly Professor Wallace, who talks about humanisation of healthcare. We need to remember that these assessments and this support is occurring within a context, within ecosystems. So I just want to really sort of emphasize that it is a village approach with the family at the center. What are their ideals? What are they concerned about? It needs to be developmentally kind. Where are the family at? How can we support them? And offering them accessible information in the most accessible way that includes consent and assent of those children. And also baselining. Get your baseline. What does it look like without a valve, with a valve, and continue to monitor. Setting realistic functional goals and intervention that not only talk about red flags, but talk about what does good look like for this family. So in summary for this, what we're saying is for children, young people, we need to remember there are different contexts, that some children will be really successful, some children will need to be a watch and wait or a return, but be curious, and some children a one-way valve may not be possible, and we might need to think about alternatives.
That's great, Louise. Thank you. It's interesting to see the differences between paediatrics and adults, and we'll hear about from our adult colleagues shortly. I'd now like to introduce Viren. Dr. Viren Kuhl is a critical care physician and educator who works across all care settings in Syracuse, New York. As a strong proponent of interdisciplinary clinical practice, he is very excited to join this panel. Thank you, Viren.
Thanks for having me, everybody. So the question that I want to answer today is, how do we assess people for readiness? You know, when is it time while they're on mechanical ventilation, especially acutely, when is it a good time to try speaking valves? So one thing I want to highlight is that this is not new. We now have evidence spanning over 40 years, 50 years so with valves. And what I want to highlight that you can see in the third box is that there really have been no reported severe adverse events with using valves. So sometimes it's our fear that can stop us, but I'll give you a big motivation, which is the box in the middle. And the motivation is using inline valves, even in people who are in mechanical ventilation, can return the voice early by 11 days, 2 weeks almost. And this obviously ultimately affects recovery for the patient. So how do we assess for readiness in a stepwise manner? So the first step is the patient hemodynamically okay? And what kind of respiratory support are they on? So if you look at the broad literature on this, you can actually start using inline speaking valves at PEEPs about 10 and even 8 to 10. I have mentioned 5 to 8 here because if this is a new thing for you guys, then in your unit, it's okay to start off with people who are at least coming close to extubation. They may not be getting there immediately, but they're close. So start doing it with those folks, but you can absolutely start be manageable. That's the other big thing. And once that baseline is good, you need to get your team ready. This is a true team sport. No single member is important just by themselves. We need the whole village to work. So typically, my team will make fun of me because I'll round up everybody, right? I'll be like, hi guys, can we talk about Mr. or Mrs. So-and-so? And I'll go talk to our physical therapists, occupational therapists, speech and language pathologists, nutritionists, right? Get your team together and then set a timeline. And as part of the timeline, your first thing to do is to see how the patient does when the cuff is deflated. And once the cuff is deflated, do they have airway patency, meaning does air escape? Because if air does not escape once the cuff is deflated, then the chances are they still have edema in their trachea and they may not be able to breathe independently or vocalize once you deflate the cuff. And then remember that once you have tried somebody on a valve, you can go slow. Start with a 5 to 15-minute trial. We don't have to go for a whole half-day attempt off the bat. And sometimes, even before I try a valve, I'll have the patient, cover the cuff with just their finger and see if they're able to talk. And that's already and that's part of patency check anyway, but it's a great way to see, hey, see, you can be fully involved with this off the bat. You sometimes don't even need the valve, but of course, the valve is a more durable option. Okay, so some big do's and don'ts. I've left this in case you have access to the slides. The big do's are make sure the cuff is deflated fully. Make sure you do the first trial with the whole team at bedside, and remember that the valves are safe. Things not to do. If the patient has a lot of unmanageable secretions, have a plan for them. I'm not saying don't do it, but then as Haley was saying, sometimes you may need a lot of frequent suctioning, and that's a strategy. It may be time consuming, but that's okay, but it needs a strategy. Make sure we do not do this in people who have laryngectomies because they have no connection between the trachea and upper airway. And finally, if people have foam cuff tubes, remember those can't truly fully be deflated sometimes. You run the risk of total airway occlusion in those patients, so make sure you're using the right kind of tracheostomy tube before you do any of these trials for these patients. So what I typically monitor in these patients is 4 things. How's their oxygen parameters, right? And what I want to share with you is that we have very good evidence that I've put in these slides that valves by themselves do not cause de-recruitment. It's a myth. They, in fact, do not impact your recruitment status. So please don't worry about them, but monitor their oxygenation, monitor their clinical work of breathing, accessory muscle use. Is there any diaphoresis? Is the patient having any struggle with valve use? And then 2 things, monitor their voice and monitor their secretions. Are they able to process secretions? Because what you don't want to do if they're having trouble managing secretions, you don't want them to have aspiration pneumonitis because that might put them a little bit on the step back, okay? So just monitor those 4 things. And remember that if at the end of the day, there's a failure during trial for any of those reasons, just remove the valve, recheck the patency, clear the secretions, and ventilate the patient, and you can go back and try another day. And it's okay. Trial is important. Now, I often get asked, can you use them in line with ventilators? In people who are requiring ventilator support, you absolutely can. The only big difference is the patients learn to breathe once the air is being sent in by the ventilator, and they just have to use that diversion to vocalize. And in fact, even in these patients, like I said, voice returns 11 days sooner. And remember that in these people, early communication will lead to significant improvement in quality of life. It is a big, big deal for people. It humanizes machines and acute illnesses, sometimes chronic illnesses also, like Haley has pointed out.
Thank you so much, Viren. And I totally agree with you. The whole team is so important in making assessments and decisions around speaking valve use. And now I'd like to introduce Michelle and Lisa. They are going to be doing their talk together. Dr. Michelle Payton is a cardiorespiratory physiotherapist and clinical researcher with extensive experience in critical care rehabilitation and recovery after critical illness. She's a research fellow at Monash Health and has led research investigating exercise, mobility and rehabilitation interventions in intensive care. Through her clinical and research work, Michelle has developed a strong interest in strategies that enhance communication participation and quality of life for patients with tracheostomies. She is passionate about multidisciplinary, patient-centred approaches that support meaningful recovery across the critical care continuum and regularly presents at national and international conferences. And we also have Lisa, who is a critical care clinician with over 20 years' experience in public acute healthcare, specialising in dysphagia, altered airways and cardiac care. As a Grade 4 clinical practice lead for dysphagia and altered airways at Monash Health, she co-leads the Altered Airway Management Outreach Service, providing clinical leadership, education and multidisciplinary support. Lisa secured competitive grants to establish a specialised multimodal speech pathology service for head and neck oncology patients with altered airways. She also co-developed the multidisciplinary tracheostomy simulation program at Monash Health Simulation Centre, enhancing multidisciplinary clinician capability and competency in altered airway management. Thank you, Lisa and Michelle.
Thank you so much, Sandy, and thank you for the opportunity to speak today and share how we implement Passive valves within our critical care service here at Monash Health and how we support our adult patients to progress towards successful inline PMV use. So before discussing inline PMV, we'd like to briefly introduce the model that supports trachea care across Monash Health. So Monash Health provides trachea care across 6 hospital sites spanning ICU, acute wards and rehabilitation. At the centre of this is our Altered Airway Management and Outreach Service, or AMOS. And AMOS provides leadership for tracheostomy and altered airway management through clinical support, education, governance and continuity of care across a patient journey. Today, we'll focus on how this model has helped move PMV from a specialist intervention towards routine critical care practice.
Sorry, that's me. So as we've already heard through the session today, successful PMV implementation is very much a multidisciplinary process. At Monash Health, patients with a trachea are supported by intensivists, the surgical teams, physiotherapists, speech pathologists, nurses, and importantly, the patient and their family. Each discipline does bring a different perspective, but we share a common goal of really trying to maximise recovery, participation, and improve the quality of life. So as a physio, our role is more to identify probably opportunities during the ventilation weaning and to assess the respiratory stability, secretion management, and cuff deflation tolerance. Our speech pathologists assess the upper airway function, communication, voice, and swallowing, while the nurses provide more ongoing monitoring and support through the day. Medical teams oversee the airway management and suitability for progression. Sorry, Sandy, we haven't progressed to that slide yet. And importantly, I guess as we've heard as well, PMV implementation is rarely a one-off event, and patients often require some multiple assessments and multiple trials as their condition evolves.
So as we've heard today, the benefits of PMV extend well beyond restoring voice. They may include improved communication, swallowing, secretion management, rehabilitation participation, and quality of life, very important. At Monash Health, referrals come from a broad range of patient groups, including neurological, respiratory, trauma, and complex medical or surgical populations. And importantly, candidacy is determined by an individual's goals, airway status, and overall clinical picture, rather than the diagnosis alone. So rather than focusing on the why today, we'd like to focus on the how. So once we've identified a suitable patient, how do we progress them towards successful inline PMV use?
So Viren has already covered some of the readiness assessment in detail, so I'll focus more on the practical considerations. We generally consider three main domains. So first, the respiratory stability. Patients don't need to be off the ventilator, but they do need to be able to tolerate the additional workload that can be associated with cuff down breathing. So we do need some fairly stable respiratory parameters. Secondary, they need upper airway airflow. So we need confidence that they can exhale effectively around the trachea tube and through into the upper airway. And third, secretion management. So patients don't need to have minimal secretions, but they do need to be able to manage them independently or with assistance as the cuff does need to be deflated. So if all of these elements are present, then we do begin progressing the patient through our communication pathway.
Once we've identified a patient who may benefit from a PMV, we rarely move directly to an inline trial. Instead, we use a staged progression pathway that progressively restores upper airway airflow and assesses tolerance along the way. For many patients, the first step is above cuff vocalization or ACV, and this allows airflow to reach the upper airway while the cuff remains inflated and provides an early opportunity for communication. The next stage is ventilator-assisted leak speech or VALS. With cuff deflation, a proportion of inspired gas is redirected around the trachea tube and through the upper airway, and this helps us assess as a team the tolerance of cuff deflation and that airway patency. And then the patients may progress onto a supervised inline PMV trial, initially for short periods before gradually increasing duration as that tolerance improves. Progression isn't always dictated by a timeline. Some patients move through these stages really quickly, while others remain at one phase for some time. And our role is to continually reassess and address barriers as they arise.
One of the most common concerns when commencing inline PMV is the ventilator. And our key message isn't that it's more the patient physiology that's important compared to the ventilation mode that they're actually on. So if a patient can tolerate the cuff deflation and the upper airway breathing, a PMV can generally be incorporated across a range of different ventilation modes. But clinicians do need to understand that the ventilation parameters will change because exhaled gas is now being redirected through the upper airway. Exhaled tidal volume, minute ventilation, and some disconnect alarms obviously won't behave as they normally would. So this often requires adjustment of alarm settings before commencing a PMV trial. And some patients might also need adjustments to ventilation settings following cuff deflations. The PEEP or positive end expiratory pressure is often reduced on the ventilator as the valve provides a degree of physiological back pressure. And pressure support or tidal volume targets might need to be adjusted depending on the work of breathing, the comfort level, and the voice quality of the patient. We also spend time preparing staff for the differences between a dual limb and a single limb circuit. So for us in the acute setting in ICU, we predominantly have the dual limb circuitry, which generally makes implementation relatively straightforward. Single limb circuits are obviously encountered more in the subacute or community settings and do require some additional consideration regarding the valve placement in relation to the expiratory port so that we're not affecting the triggering and cycling of the ventilator. But ultimately, our focus remains on the patient. So we're monitoring the work of breathing, their respiratory rate, comfort levels, voice quality, and overall tolerance. And once clinicians understand the expected ventilation changes, an inline PMV becomes significantly less daunting.
So up until now, we've focused on individual patients and individual PMV trials. However, introducing a speaking valve or a PMV successfully on one occasion is very different from embedding PMV into routine practice across a large health service. So at Monash Health, we've focused on building capability through education, collaboration, and the development of local champions across the network. This includes cross-site education sessions, bedside teaching, practical implementation support, and targeted discussions with local teams. The focus isn't simply on performing a PMV trial, but helping clinicians recognise suitable patients, understanding the pathway, and troubleshooting challenges along the way. Our local champions are a key part of this model, helping reinforce safe practice and support PMV implementation when the specialist service isn't physically present.
Education alone isn't enough, though, to create sustainable change. If PMV is going to become routine practice, clinicians need a consistent framework that supports them beyond that initial training session. To achieve this, we developed some standardised procedures, competency requirements, and clinical resources that provide clear guidance around assessment, implementation, monitoring, and escalation. These resources are reinforced through regular AMOS meetings where clinicians discuss challenging cases, share experiences, and maintain consistency across our health service. Ultimately, our goal isn't for PMV expertise to sit within a small group of clinicians. It's to create a system where the right patient can access PMV at the right time, regardless of which ICU, ward, or hospital they happen to be in. And that's how we've approached building our online PMV capability across Monash Health. Thank you.
Thank you.
Thank you. I agree totally. It's so great that you're able to empower other clinicians, and so you're not waiting, Monday to Friday service to come in and do all of those things. I'll hand over to Michael now.
And now we will enter the panel discussion. So I'll invite all of our panelists to turn their cameras on. And I'm going to return to a theme that the panelists identified early in the preparation of this webinar, the theme of not now, but later. Here, this is speaking sometimes to the timing of an inline, or sorry, a one-way speaking valve. This theme of just because it didn't work now doesn't mean that it can't work ever. Haley, in your story about Weston's journey, there was a pretty potent, moment or demonstration of this theme. What motivated you to try the speaking valve again? You mentioned that it was like a light switch.
Well, if I'm being totally transparent, it's because I was losing my mind. Um, we dealt with these excess secretions. He came home April of 2024, and it was like it was on from that time up until we were successful with the speaking valve. I just so badly as a parent wanted better for him. I wanted to watch him grow. I wanted to watch him walk and run with his older sister. Every parent wants that for their child. And while facing his unexpected diagnosis head on, I had to kind of shift gears a little bit. And my biggest thing in life now is like advocating for Weston and making sure that, he gets to do what I want him to do and what I think he's capable of. And like I said in my talk that, I left feeling discouraged from a lot of the appointments, but that's because I heard this quote a lot of times is keep things status quo, because he was otherwise healthy and doing okay. But I just didn't find that was acceptable. So I did my own research, and with the help of you in particular, Weston is where he is today.
That feels like an important theme for us that I'd like to dwell on just for a little bit. Haley said that she had a hard time starting up this conversation with the medical team about reintroducing, not necessarily a speaking valve, but addressing one of his about something that afflicted his quality of life. For the other healthcare providers on the panel, what are obstacles that you can imagine that would make it harder to engage the use of a speaking valve?
If I could speak to that just from a pediatric perspective, and I think one of the challenges, and certainly Michelle and Lisa spoke to this, is around competency and skill associated with assessment and introducing one-way valves. And I think depending on the setting that you end up in depends on the skill and the team around that child. And that can be, I absolutely hear Haley's frustration. You can hear how the lack of resource, whether that is skill or human or otherwise, and even location. We're talking about families in, that are near to perhaps centres where they have all that specialist skill, but what about the family that are out in remote, isolated settings? How do we empower them to make informed choices and support that empowerment process? That it's, Haley knows Weston better than any of us could ever know him, even if we spent every day with him, right? So how can we use that and harness that? But I think my own personal experiences, and certainly what I think education is very important, is how do we take education and escalate it so it's not just about knowledge, it's how do we translate that? And again, Michelle and Lisa, it sounds like you've got some great stuff there. How do we extend that out into communities so that families get the support when they need the support, and adults as well in that respect?
Michelle and Lisa, how do you meet the obstacles of reluctance or hesitance to employ a speaking valve, especially if a speaking valve or any attempt for vocalization didn't succeed the first time?
Oh, do you want me to jump in first, Shell?
You go first, yeah.
Yeah, sure. Look, I mean, from my experience, I don't feel like we have so many obstacles popping them on and trialing them, particularly in bed-based. I think it's quite a well-established service. Louise, yeah, listening to your point about education and we were a long way back, 20 years ago, 15 years ago. We've put a lot of work into, our competencies and skill development across a very, very big network in Victoria. It's the largest health network in Victoria, but it certainly didn't happen overnight. But we're very proud to say that we've got a pretty well integrated service now. And I think it actually reaches beyond the hospital walls now. We have a telehealth service that we run, or the speech pathologists run out of one of our campuses, that outreach to all our altered airway patients that can help troubleshoot and support our patients with trachees and PMVs in the community. So that is something that we have now set up, which just promotes that sort of community practice and supporting communication in the community. Jump in, Shell.
Yeah, I was just probably going to add that I think it's definitely around and I can never say the word, familiarity and I suppose exposure. So when you have your champions who are comfortable and knowledgeable and can keep questioning the status quo, that's when you get change. And Letha and I have been at Monash Health for a very long time now. So I think we've been able to embed ourselves into a lot of processes. A lot of consultants know us very well, and I suppose have that understanding of our knowledge to be able to then, when we're coming to them saying we do feel that this would be of benefit, that they do stop and listen. So it does take time to build that service and to build that knowledge into a service. So if you're in a service that doesn't have that, it really is about empowering yourself first to make sure that you have the knowledge and you have the understanding, and then bringing in your champions. So making sure you've got some medical leads or some service leads that will advocate with you. And then once you get the ball rolling, it does start, but you do need just to get that push at the beginning.
Viren, a very particular way I'd like to take this same theme and to hear your thoughts. You say that you love talking to everyone. Speech therapy, physical therapy, occupational therapy, respiratory therapy. Get the patient's family member in here too. How do you navigate hesitation or concern about speaking valves, especially if there's been a precedent or a previous event in which the speaking valve was not tolerated well?
As I was listening to everybody else, I was going to highlight that a lot of times our experiences are sort of influenced by previous occurrences. And I think how you deal with them can be groundbreaking in how you go forward. So if your team is, this is why we debrief. So if something doesn't go well when you implemented it, you have to acknowledge your team's discomfort. All these things we're saying today, you have to say, you know what, guys, that did not go well. And you know what? Let's see why it didn't go well. And let's come up with a plan on what to do if we try again and the same issue occurs. So when you think about it, we do this with almost every part of practice. So as an airway expert, you have difficult intubation. Sometimes you can't intubate, but that doesn't mean we don't intubate the next patient because we're scared. So I've always found that if a bad occurrence does happen, actually dealing with it openly and transparently is absolutely critical. If you either not ignore it, but you just hope it's going to go away, it's not. It's going to leave people worried. Or even worse, if you dismiss it, saying, oh, no, that was just a one-time thing, that also will have your team judging the next time. So I would say if you've had a untoward experience, take it and say, hey, let's make a plan for it. This is what we're going to do differently. And actually, while we're at it, can you think of other things that could happen similarly? Why don't we plan for them too? And now everybody's bought in, right? They're like, okay, it's okay. We have a plan. And it's worked for me almost every single time. So that's what I would do.
Negative feelings that aren't brought out into the open, they have a habit of just festering and transforming into something else. I'm going to read out now some questions that we got from the audience. First one, this is probably going to be more towards Viren, Michelle, or Lisa. So put your hands over the buzzers. How would you apply speaking valves, or what considerations would you make in applying speaking valves in patients with rapidly progressing neurodegenerative diseases like ALS? Viren.
So much like a lot of interventions that we do in advanced neuromuscular diseases, I think speaking valves should come with the goals of care discussion, right? And the way I do it almost in every single one of those patients that I take care of is, hey, what are the two if time, money, and reality of life was not a constraint, what are the three things that are important to you, right? And that is key. Why is it key? Because if they tell you that, hey, I just don't want to experience shortness of breath in my 3 months or 4 months, whatever time frame you're looking at, that's what I want to avoid, then that's one thing. But if they tell you, hey, I want to be able to talk to my family, then that changes things, right? Because it gives you a risk tolerance. And the way from there I go and say is, hey, we're going to try this. Speaking, phonation takes effort. And some of that effort is used for your breathing purposes, for your muscles. We can share that burden. And I have a whole team here. But you tell us where you want to expend most of your energies. And I've had people who have said, I want to focus on phonation, and it's okay if that spends me for the rest of the day, I'll rest. And others say, hey, I just don't like feeling short of breath at all. And you know what? Two people may choose completely different things, and one's going to go with a speaking, one-way valve, and they take it as fighting, and you support that spirit. And the others say, I want to spend time in comfort with my family, and that's also okay. And then I don't try it.
Yeah, I
Michelle.
think just adding to Viren's comments, because that's very true. I think you put the patient at the center of the discussion and the decisions, and it's very much outlining the risks and benefits. So we do put PMVs in ventilation circuits, even knowing that it may increase the risk of aspiration, which may lead to further deterioration. But if that is what the patient wants in terms of being able to communicate with their family, then we obviously try and empower them to make those decisions. It is just making sure that decisions are being made with an understanding of the risks and the benefits of what they're signing up for. So again, that education aspect, not just to the medical teams and the nursing teams looking after them, but to the patient and the family, so that they are making an informed decision as to what they're actually achieving.
Another question. This is probably more in line, more in the wheelhouse of Michelle and Lisa, but open to everyone. If a patient fails an above cuff vocalization trial due to something like vocal fold paresis or paralysis, would you still proceed with an inline speaking valve trial?
Good question. Depends, I think, is the answer. We don't tend to put PMVs on a bilateral vocal cord palsy, and that's just purely from a risk. Obviously, the patient won't be able to breathe depending on what position the vocal cords are sitting in. We'd probably want clearance from the doctors and our ENT surgeons regarding the upper airway and what the cords are doing from a function point of view, but it's not something we would exclude. We would certainly consider it and look at it. Yeah, if it's a unilateral palsy sitting in a fairly decent position, we would progress to leak and then to inline.
Another question. Oh, Haley, go ahead.
I just want to speak on that for a little bit because Weston was actually diagnosed with bilateral vocal cord paralysis. And before he had a scope done to show that he had full recovery of his vocal cords is when we tried the speaking valve. We actually tried it before that, oddly enough. And he was healing, I'm sure, slowly over time. But it was, he failed it at first, and 4 or 5 months later is when he was successful with it. So
I can't remember if I can take credit for trying the speaking valve before the vocal cord paralysis was cleared. I don't know if that's something to be proud of or not.
Well, I will say it was, we were talked about in office, but we didn't trial it in the office. We tried it at home. In his bedroom floor is when I heard his voice the first time.
Um, Luis, I'm going to direct this third question to you. Here, reading the question verbatim. Some team members I work with are reluctant to apply a speaking valve to patients unless they have a cuffless trach. How would you advocate? Oh, and inline valves are rarely available at my site. How would you advocate for earlier use of one-way valves?
Thank you. It's a minefield, and I think, and again, adults and pediatrics might be slightly different, and globally, this is very different how cuff tubes are used, for example. And they seem to come in out of favor of my career, in out of favor, depending on what center you're in. And primarily, they're used for children with ventilation needs, right, to maintain, to prevent, to optimize ventilation. I think it's about the team around. So for me, it's not they have a cuff tube, that's no one-way valve. That's not a hard no for me, definitely not in my clinical experience, but it's about how you support the understanding, because placement of a one-way valve on an inflated cuff is a risk. And as I commented in my presentation, even a millimeter change in that airway can cause an obstruction in an infant. So it's not just about the type of tube, it's also about the size of the tube. I think that's probably my first go-to. You know, I want a child that has a tube that's aged to them appropriately, and then half a size smaller is typically what we would go for clinically. So, you know, if they're between a certain age, they would have a certain size tube, and then we'd go down a size. So we've got that leak, which certainly Michelle and again, Lisa, you've all talked to this about that leak speech and that leak, that passivity. So we're getting that airflow. It's not always an indicator. It's not always an indicator of success. Children physiologically respond differently to a valve placed. And in terms of access, it's really challenging, and I appreciate this globally. And there are different types of valves out there, and I think it's exploring what's available, exploring what options are available in terms of the experience of assessing the patency of the upper airway and occlusion of the trachea to allow voicing. That doesn't mean stick your finger over continuously, because that's blocking the whole tube. They need to breathe in at some point, which is my pet peeve. But you know, it's supporting that, and children explore that themselves. So I don't know if that answers it fully, but I acknowledge the challenge globally, and that's a health disparity resource issue. It's seeking those options and advocating. You know, it's not just saying it's a speaking valve. It is saying it is a multifunction valve. It has multiple impacts. No doubt with Hayley having experience even in vocal cord palsy of airflow, having that experience for sensation, for secretion management. It's a huge opportunity. And how do we advocate and stand by our families to say these are human experiences that they should have access to?
Last question from the audience. Maybe the last question from the audience. Do any of you use a Buchanan bib for speaking valve or for humidification? And I just had to Google this because this is the first time that I've encountered that. In case I'm not the only one who didn't know what this was, a Buchanan bib is basically an HME that you can wear all over your neck instead of just on the end of the tracheostomy tube. But for those of you who use this regularly, please enlighten. There's the question. Luis.
So my general conversation is a Buchanan bib is used as a bib in children. It's not actually used for humidification, as in it's placed over, and it's kind of more used as support. The reality is the one-way valve is an inward, so you're not getting that humidified air. It's not coming back out the valve. You need the Buchanan bib to be moist to act like a humidification, a HME. Also needs to be tucked in because any airflow underneath is dry. So for me, it has benefits if you haven't got a valve on. The evidence suggests it has limited humidification benefits, but in a one-way valve, it's covering the one-way valve and acting as a nice dribble catcher in pediatrics.
Michelle.
I was just going to add that, yeah, obviously the valve is still allowing airflow in. So the majority of air is still going in through the tracheostomy tube. So you do want to humidify the air going in. So even in a hospital setting, standard care is utilising the airvo over the top of a Passimier valve with the flow of at least 30 litres. So we're meeting the humidification requirements that the patient requires.
Okay. I'm going to give all the presenters here an opportunity to give a one-line conclusion or takeaway for our audience. I'm trying to speak slowly and to drag out my sentence so that you can start forming that one-line summary. Haley, I'm going to start with you. What's the one line that you would like for our audience to take away tonight?
I guess coming from a parent, just advocate. Don't give up.
Luis.
I'm going to jump off the back of Haley, and as a clinician, be curious and support advocacy. It's really important.
Viren.
It's my favorite line in the ICU. 1 hour was a century ago. Today's a different day. So start fresh, you know?
Lisa.
I'm going to stick with the theme of not now, not never. Really, really like that, and approaching that not in silos, but as a team.
And Michelle.
Probably my big point is don't be scared of giving things a go. Yeah, people want to know and feel comfortable doing things, but you've always got to start somewhere. So, everyone, especially putting things into a ventilation circuit, people do get concerned about it. But if you have enough theory around how a ventilator works, it's not as scary as what it seems to actually put a valve into that circuit.
The final comments are just going to be about the Global Tracheostomy Collaborative and its other activities. If you loved our webinar, you should come see our next webinar, which is going to be November 5th at 4 p.m. And if you like learning about tracheostomies and you want to participate more, you should go over to our website at globaltrach.org. Become a member. People who have previously signed up need to sign up again ever since we've created our new website. Unfortunately, the membership banks did not carry over. While you're there, you can explore the education topics that we have. Also, if you really, really like learning about tracheostomy tubes and engaging with other healthcare providers and family members, you should come to Melbourne, Australia on October 1st because it is the 10th International Tracheostomy Symposium. And even if you didn't want to go to the symposium, you should just go to Australia. Easier said than done, right? Finally, if you still have a lot of things to talk about and you want to share the success that your institution has been having with tracheostomy patients, you should submit your work to the Tracheostomy Journal, edited by very active members of our Global Tracheostomy Collaborative leadership. That is all for this third quarter webinar from the GTC. I am Michael. I am your education chair, and thank you very, very much to my co-chair, Sandy Foster, for facilitating this webinar. Thank you most of all to the presenters for sharing their time, their expertise, and their stories. We hope to see you in November. Bye.